ايش علق؟ دكتور وليد تعشيت ولا لسه؟
لا done. مساء الخير، أهلا وسهلا بكم في محاضرة هذا المساء، وهي بعنوان كيتامين ثيرابي فور ديبريشن. يقدمها الأخ الدكتور ناصر الشريقي، مستشار الطب النفسي في عمان بالأردن، وهو من الأطباء المعروفين الناجحين في هذا المجال، وله خبرة في موضوع الكيتامين. تفضل دكتور ناصر.
مساء الخير والله يعطيكم العافية. وبناء على طلب الدكتور وليد فيسرني إني أحكي عن موضوع كيتامين ثيرابي فور ديبريشن. إحنا زي ما تفضل الدكتور وليد، إحنا صار لنا شوية خبرة فيه، probably إنه نقدر نحكي شوي هيك من شوية خبرة صارت عنا في الموضوع. يعني recently في emerging research supporting that ketamines إنه له rapid antidepressant effect، وإنه it's very effective بال severely depressed suicidal patients، وإنه reporting very good results. Mainly the use of ketamine is mainly for resistant cases. The EMA, the European Committee for Medicine Agency defined treatment-resistant major depressive disorder as a poor or unsatisfactory response to two antidepressant treatment in the current depressive episode. If we use 1 and 2 medications with no response, is considered as resistant depression. من كل قصة الكيتامين came from National Insurance Mental Health في Mount Sinai School of Medicine in New York. Ketamine is FDA approved anesthetic agent. It's not approved for depression, but approved for anesthesia. It's used by veterans treating animals, agitated animals. له high affinity non-competitive NMDA N-methyl D aspartate receptors إلى glutamate pathway. It's classified as Schedule 3 non-narcotic controlled medications. في له affinity في كثير risk of being abused by street drugs. Ketamine is this a dissociative agent and induces a trance-like states, painkiller, sedative, and it's useful, very useful in cases of في الانستيزيا للاطفال اللي عندهم they have emergencies and they have no harmful effect on the heart or on the lungs. مثل cases like cases with obstructive airway disease, that's very safe medication, and sometimes they don't use ventilating equipment. It's NMDA receptors antagonist. It's not classic. You know that glutamate is excitatory neurotransmitter involved in learning and in memory. It seems that ketamine actions is not only restricted to NMDA receptors, it's more sophisticated than that, and it seems to affect also the opioid monoamine oxidase transporters as well of dopamine, serotonin, and norepinephrine. Increasingly evident that that ketamine is useful in emergency department of useful in hospitals treating severe depression or suicidal ideation. Then at 2015, started to do study to be sure about the efficacy of ketamine versus placebo in unipolar cases. So they give intravenous only single dose. They started with a single dose of ketamine infusion, about 0.5 milligram per kg, and the other group of persons were giving nothing, and they were studied after 24 and 72 and 1 week, 24 hours, 72 hours, and 1 week. And in 2 weeks, they found that the patients saw significant improvement of depressive features at 1 day, 3 days, and 1 week, and not on 2 weeks. That's a single dose. And that they found it's superior to placebo with regard to the depressive features. Ketamine comes in 3 forms: intranasal, intramuscular, and oral. We are talking now exclusively about the intravenous ketamine. Another studies trying to compare ketamine with active placebo, and that's they compare two controlled trial, randomized controlled trial of patients given again a single dose of ketamine versus patients given midazolam, just to give the sedation experience to like it seems like active placebo. And again, the primary outcome was change in depressive severity in 24 hours after drug administration, assessed by the MADRS and other tests. It seems that ketamine was again, it was only single dose, was superior to midazolam, and the improvement, the response rate was 64%, and the response was 64, and the remission was 28%. We're talking about 1 single dose. Another study, again, doctors or researchers started to become more brave in giving the ketamine for that purpose. So in this study, they gave twice daily infusion of ketamine, 0.5 milligram per kg, administered over 100 minutes until either the remission achieved or given for infusion, either for infusion twice weekly or until the patient gets better. 5 out of 10 patients achieved remission status and no significant increase of there's no shift towards mania. And that was reassuring that no one of the patient, half of the patient improved, no one of the patient shifted to the manic status. Conclusion that the ketamine infusion, lower rate than previously reported, had demonstrated efficacy and excellent tolerability and safety. Another study which comparing that 2015, comparing the ketamine with the ECT, and they found that the ketamine superior to ECT in 24 hours, 72 hours, and 1 week and 2 weeks, with regard to mainly with the suicidal thoughts and mood. And there's no shift to the manic status. There's no similar study on the bipolar patients about the risk of shifting to at that stage to the in bipolar depression. Here, meta-analysis of the efficacy of ketamine unipolar and bipolar depressed patient. Here, it's started now to include patients with bipolar in their studies, that 2016, and also and go back to it. It was double-blind and show equal efficacy with ketamine with the unipolar and bipolar, and there is no manic switch. Here they started now to be brave to include patients with bipolar. And this study is an interesting study. A patient on escitalopram 10 milligram, given for 4 weeks, given with it only single infusion of ketamine. And they found that the response rate was 92%, and the remission rate was 77%, when comparing with the ketamine, with the placebo. Patients giving ketamine with escitalopram, patient giving placebo with escitalopram, and the patient with the ketamine, the response 92%, and the remission was 77% compared to placebo, 57% and 14% respectively. Here, another interesting study in the outpatient clinic and the military, an American military emergency clinic. What they did is they give IV ketamine, and to some patients, other patients give them normal saline as placebo. And they found that the patient given the ketamine, that they give it for suicidal patients. And they found that the patient who has received ketamine started to have the suicidal thoughts subsided within 4 hours. And the patients who continue to be given during the hospitalization ketamine, and the other given placebo, and they found that the improvement lasted up to 2 weeks after discharge with the ketamine patient. This is a study about the intranasal ketamine show that added on medication and with the patient's regular medication, and found to be effective and up to 2 months of treatment. Again, another intravenous study of ketamine. People now encouraged to keep trying. In 2018, the dose usual 0.5 milligram, and they were looking at the disappearance of the suicidal thoughts. Here again, they started to increase the sessions of ketamine up to 6 sessions. In this study, 6 ketamine infusions, they found to be safe and effective in patient unipolar, bipolar. Researchers encouraged to give it to unipolar, bipolar, encouraged to increase number of the sessions. And in they found that the rapid and robust antidepressant effect and reduced of suicidal thoughts. Another study in again here against 6 infusions of 0.5 milligram ketamine repeated, and they focus in this, use the scale for suicidal ideation in addition to MADRS, and the results showed that the significant in this study they focus on the suicidal ideation, and they found how it's immensely effective with the suicidal thoughts and obvious reduction in the suicidal thoughts. This is another Indian study. All these studies, the IV studies, only medications, not added on. There's no regular medication, only ketamine, and found that the rapid and that's 2019, and rapid effects for both depressive and suicidal thoughts. Here, more a naturalistic Canadian study, and giving in this case 8 sessions of ketamine. The number is increasing with time as people encouraged to give higher more sessions. And again, the results, this is naturalistic study of real patient, not research patient, real patient, natural, there's no placebo in these studies, and found that suicidal thoughts had significant reduction, and found that the IV ketamine is effective and safe. This study, again, in I can see clearly because it's partially covered by the, again, another study which showed, I'm just talking about the date of the study. 2000, that's the retrospective study, 2012.
2022.
But I'm not seeing, because of the pictures, photos, I don't see very well. They found that the naturalistic sample of treatment depression, repeated ketamine infusion significantly decreased depression as nothing. It's covering these.
Also 22.
Okay. That's a very recent retrospective study in September, 12 September 2012, reviewed all the cases of treatment-resistant depression in 100 centers in America treating patients for resistant depression. They took all the patients and reviewed all the patients treated from November 9th, 2017 till May 2021. And the results showed that the response rate of all these patients, 50%, and the remission, 20%. The response and remission rate were, that's after this long time, but the response and remission rate was 72% to 38% respectively after 10 infusions. Here, the patient continued to receive infusion after the first 6 infusion. Then they given a kind of maintenance ketamine, like on monthly basis. Up to 10 infusions, the response rate was 72%, and the remission was 38%. And they concluded that that's retrospective, including most of the patients receiving treatment during that period, 100 center in America. and concluded that it's effective in reducing the suicidal ideation and depression and anxiety. Medical legal issues here, it's classified Schedule 3 drugs. There is a potential abuse, should be looked up carefully and protected carefully, and the name of the patient should be written, and the name of the doctors who prescribing the medication should be mentioned as well clearly on the prescription. For medical legal aspect, again, ketamine is illegal medications, but it's off-label. Off-label means that anything's wrong when the doctor takes the full responsibility. But given that ketamine is a very safe medication, and from our experience, international experience, hardly ever there is any complications. Therefore, we concluded that there is no a real risk of ketamine. Why ketamine is off-label? Ketamine is off-label because it's cheap. It's cheap medication. No company is bothered to pay the FDA, the American FDA, the money to do the stages of research, the 4 stages of research, 4 phases, before they apply for it to be, takes time, takes a lot of money. And because the medication is cheap, nobody is bothered to do it. That's the only reason ketamine is not, because the risk of addiction is applicable to ketamine and to nasal spray as well. Both are can be addicted to. So ketamine, the problem with ketamine is it cheap and considered now off-label. Off-label means that the safety, it's purely the doctor responsibility. A quick review of studies we have done in the hospital and my clinic. In the hospitals, we reviewed the total 168 patients. Only 125 completed the study, 74%. It's from the hospital study from 2014 to 2017. And the clinic patients, they are from May 2019 till August 2022. And the number of patients were 28, 25 completed the study, 3 dropped out, actually dropped out by myself. I stopped them, 3 patients. Gender, it's more like male more than female at the hospital, and the same thing in the clinic. They were more non-Jordanian in the hospital study, but more Jordanian in the clinic study. The age group, it's from 30 and above, similar. If you take it every 10 years, 30 to 40 to 50, and above 50, almost the same number. Similar in the clinic study. Significant improvement of the study in the hospital study was like 73%. And that number is very similar to the international numbers. The number of cases improved in the clinic is 68%. The average improvement is from 2/3 to 70% improvement that most of the international studies. Who are the patients who get better? Not every patient gets better. We learn who are the patients who get better from our experience at the hospital. Anxious anxiety improves. Suicidal thoughts, 100% improvement. Agitation, 100% improvement. And PTSD improve as well. Unipolar, probably more than the bipolar patients. Alcohol, here alcohol dependence after they discontinue alcohol, 61% improvement. Okay, personality disorders are difficult cases. They don't respond well to ketamine. Only 30% improved on treatment. bipolar less than the unipolar in our study. Schizophrenia, depression in schizophrenia or schizoaffective, no improvement at all. Schizophrenic with depressive features and schizoaffective patients tried on, they didn't improve. In clinic studies, we have one patient ADHD. We can't really conclude much from that, but he had improved. One alcohol dependency didn't improve after he stopped drinking, of course. Multiple substance abuse, again, after they stopped taking drugs, 50% improvement. Interestingly, in the clinic, one patient partial complex seizures and the other simplex partial seizures both improved the depressive features. Suicidal ideation, 9 patients, 9 of them improved with regard to the suicidal ideation. How do we assess patients? We used Beck depressive inventory and Hamilton. We did the Hamilton depressive scales. All the patients, on average, they went down from Beck from 34 to 16 and Hamilton from 21 to 10. The clinic studies, Beck went down from 36 to 15. The dropout in the hospitals, 50% of the dropout was due to side effects, and the other no improvement. The 3 dropout from the clinic study, one appears to have psychosis, which we were not aware of before the study, and when we found that he is psychotic, we stopped the psychotic depression. During the sessions, he showed features of psychotic depression, so we had to stop the study. Another 2 patients, the multiple substance abuse, we checked out and they found that still taking drugs, so they were dropped. They were asked to leave, not completing the study. So in conclusion, intravenous ketamine therapy appears to be rapidly effective in major depressive and bipolar depression, particularly rapidly effective in actively suicidal depressed patients, significantly effective in patients with anxiety and agitation as well. Ketamine therapy is not to be found to be effective in depression with psychosis, in depressed patient with morbid personality disorder such as borderline personality disorder and addiction. Hadi, what I had to say, and thank you very much.
شكرا جزيلا دكتور ناصر على هذا العرض الرائع. يعني في حسب مراجعتك, what is the longest follow-up period available so far?
Yani, I have patient, I gave them ketamine during the hospital time. Let me give you an example of a patient. Giving a patient with resistant depression, giving ketamine in 2015 in the hospital. And she continued to see me after hospital in the clinic. And she was perfectly well until she got corona infection in February this year. And she received ketamine in 2015, 6 sessions, and she improved significantly. And she didn't need anything apart from the usual treatment. In February this year, she had infected with corona. And after corona, she started to have shortness of breath for 1 month, thoroughly investigated, all results came normal. Soon after, she got depression again, and it was massive. And we built up the dose, increased the dose, did another combinations. It didn't work with her. She asked for ketamine because she tried it before in 2015. And this patient improved once again with the ketamine. I forgot to mention, we tend to keep the patient on medication in our studies. We don't stop the regular medication. We give ketamine added on her regular medication. That's the way we do it previously and up to now. We don't stop the medication, we keep it on there.
Any recommendation for maintenance treatment?
At times I feel maintenance treatment can be useful, but for the fear of addiction, we don't encourage that. But if we felt that this is needed, I would suggest that. Look for this lady, until the corona thing, for like 7 years, she didn't need any ketamine. And I have another one who received once in the hospital and once in the clinic, over like separation, like 4 or 5 years. It seems that maintenance, if the patient showed full recovery, not improvement, only if reached to remission stage, I wouldn't think that he or she needs maintenance. But if the patient hasn't achieved remission, or semi-remission, I would say, if we could use this term, then we'll use that maintenance ketamine therapy. But again, it's in addition to the regular medication taken by the patient.
دكتور نزار تفضل.
شكرا Dr. Walid. شكرا Dr. Nasser for this beautiful lecture. I really like the introduction that was going in a sequence of events historically. It was very nice. Although the history of this drug is not very long for this purpose, of course, it's long for other purposes. I've got probably 2 or 3 comments. The first one, I would like to repeat the same question of Dr. Walid. One example or 2 examples really is not satisfying for us when you are giving examples of the cases which are anecdotal about your cases. The question is the duration of the response. We know for sure from the literature that it's useful for cases of treatment-resistant depression, especially with suicidal ideas. But what's next? I mean, those patients usually they go back again to their depressive symptoms. But now, as you correctly said, if you keep on giving them maintenance, then there's risk of addiction. So, what was the longest duration of response among the series of patients that you saw? This was the first question, and I will give you the second question when you answer this one, please.
Yeah, as I said, we keep the patient on his or her regular medication. Ketamine is not the only medication they receive, it's added on. Apparently, I feel that ketamine helps them to go to the normal mood, then this maintained by their regular medication. The longest period we have patients receive ketamine once in their life, and they improved, and they never come back, and still they never asked for ketamine once again. I have a patient who received ketamine, still he's coming to see me, and got married recently, and he received ketamine 2016 or 15. We're talking about 7 years, and he's taking his regular medication. Even the medication he takes now was low dose medication. Like he takes Lamictal, because at some stage I suspected that he is bipolar 2 with mild doses of antidepressant. So I have patients like, that we started using this only 2014. Yes. So I have patients like 7 years, and they needed only one set of sessions of ketamine, and they didn't need to have it again. Other patients, they need it over a long period of time from the first episode, like the lady I mentioned, who received it same time, and then they had it again. She was completely functioning. She's a woman working in a company. She's accountant. She has 3 girls, happily married, and she was perfectly well. And she was cutting down. We were cutting down her medications until the corona thing happened. So I have examples of patients who only needed only one session and continued to be well.
That's a perfect answer. My second question, I've got 2 more questions, if you bear with me, please.
Go ahead.
My second question, the answer is in 1 sentence only. You've mentioned ECT. Now, which comes first, ketamine and then ECT, or if ECT did not work, then you go to ketamine?
My inclination, I'm like Dr. Walid Sarhan. I'm not into ECT unless in extreme, unless in suicidal patient, or unless an old age. I only use it for old age patient or actively suicidal, young and old. But with the ketamine, we don't need it because the suicide things can be solved with the ketamine. I go first for ketamine. And if ketamine didn't work, my final destination is the ECT. ECT is the ultimate, is the end.
Okay, the third question, the last one, I like the research that you referred to in your clinic. And one thing that attracted my attention is out of 25 patients, 3 dropouts. That's a high percentage for research purposes, as you know. And of course, you gave us an...
I took them out and they didn't drop out. I took them out. I mentioned that because 2 of them, they continue to take drugs, and I didn't allow them to continue. And the third one, he has never, it was new to me, and he was very depressed. And during treatment and follow-up, he appears to have psychotic features. And I know ketamine is not effective with psychotic depression. So it's not ethical to continue on ketamine while he is psychotic. So I had to remove him. The other 2, they were substance abusers who supposedly stopped. And again, during the sessions in between, I tested them randomly for drugs, and they found to be taking the drugs. One of them, Lyrica, and the other one was alcohol. So I had again to remove both of them from the ketamine, because from my previous experience with the hospital study, that in both cases is not effective. So it's not really worth doing it.
In fact, my question refers to the psychotic patient that you referred to. As you know, sometimes ketamine by itself causes hallucinations. Now,
that wasn't the hallucination which happened during the session. That patient in between sessions, it showed some paranoia and psychosis and morbid jealousy and some psychotic experience towards people at work. And then he appears, then I speak to his family, appears to have psychosis before, and he never disclosed it to
I see.
So we didn't diagnose him properly at the beginning. When it showed out, it's not the hallucinatory, the trance or the hallucinatory experiences during the session. Now, this wasn't the case. This we don't consider this psychosis. We usually calm the patient down, turn on the light, speak to him down. We talk him down. Usually works. So that's not what I meant by psychosis. Psychosis is something what happened to the patient in between sessions.
Okay. Thank you very much. And I again congratulate you for the great lecture.
Interesting comments and question. Great, thank you.
عندنا سؤال من مشارك مجهول، تفضل.
السلام عليكم دكتور. أنا دكتور أمين مقيم طب نفسي. يعطيك الصحة دكتور على المحاضرة القيمة. Just a small question if you don't mind.
تفضل.
Yeah, sorry. Just a small question. I was gonna ask about the psychosis, if ketamine will cause psychosis, but I think you just covered that with the question from the doctor just now. And the second question, is there any difference between the intranasal and the IV one?
Well, that's a question which I have to answer, but I wasn't really, I'm not into, because of the politics of companies, you know, they will not be happy for me to answer, but this is not, I would say, my experience with both, because we participated on Spravato as well, nasal, their study also participated with it. I think both are effective. The IV is more rapid efficacy because you are giving it within like every other day for 12 days. I didn't talk about the procedure itself, but it is like 6 sessions over 12 days, 1 day on, the day off, and like that. So it is rapid. The Spravato is only twice weekly. It's slower, and it's over 2 months. The other one is over 12 days. So understandably, it's faster, the IV ketamine. And probably faster and more effective because you are giving it in short period of time. We never tried Spravato every other day because the company says that you shouldn't do that. That's the second thing. The advantage of Spravato is that less side effects from the ketamine, from the Spravato, esketamine. And Spravato is less likely to have a trance and the psychosis, the hallucinations during the episode that Dr. Nizar mentioned. Less likely to have it with the Spravato. With Spravato, you less likely to have increased blood pressure, hypertension. These more likely, you have to be careful with the IV ketamine, you have to monitor it closely. We tested the blood pressure of the patient every 10-15 minutes in both cases. But from our experience with the Spravato, hardly ever we get increased elevated blood pressure. But in ketamine IV, we used to observe. With Spravato, less nausea and vomiting. If the patient ate something, we always warn patient not to eat anything for 4 hours and not to drink anything for half an hour. If one of the patient did it with the ketamine, had very bad throwing up and nausea. With the Spravato, it's less likely to have these side effects. So in simply, ketamine is more effective because you're giving it in shorter period of time. Spravato, it's effective, but much less, I would say, less side effect than ketamine.
What about the price, doctor? Sorry for. What about the price?
About what?
Price.
Ketamine is cheaper than Spravato, significantly. With our observation and clinical work, definitely ketamine is much less than Spravato, much less expensive.
Thank you very much.
Thank you, doctor.
Any other questions, comments? Well, if all clear, شكرا جزيلا دكتور ناصر على هذه المحاضرة وعلى النقاش الثري.
النقاش كان ثري جدا. I'm impressed by the audience, دكتور نزار والدكتور المجهول الهوية. Very interesting question. دكتور نزار أتحفنا بhis comments.
الله يخليك.
يعني we need ketamine need a workshop seminar to talk about it. It's a lot in it, and very interesting and very effective and very promising.
شكرا جزيلا.
نعم دكتور وليد، شكرا لك أعطيت لنا هذه الفرصة اللطيفة.
تسلم.
هلا يا سيدي، الله يعطيك العافية ويقويك دائما.
نراك في لقاءات قادمة إن شاء الله.
تشرف يا سيدي.
تصبحون على خير. لقاءنا الثلاثاء القادم.
إن شاء الله يا سيدي، تصبحوا على خير.
مع السلامة.